There is a small thing. This is transforaminal endoscopy under local anesthesia. That is how I have been doing it. I don't do it under general anesthesia or complete epidural or otherwise. What is the meaning of worst? When I searched on the internet, I found that it can be used as an adverb or a noun. Superlative of bad, of the lowest quality, most unpleasant, most unfavorable to us and to the patient. So anything that fits in during a transforaminal surgery is a worst complication. So you have a lot of worst complications which can happen. What are the main causes in transforaminal endoscopic surgery under local? For me, it is always incomplete surgery, intra-op complications, no pain relief post-op, and last but not the least is post-operative infection. No complications, probably you need to operate more, and local is always our best bet to do it. I am talking only about the acute complications here. Incomplete surgery, why does it happen? It happens in your early learning curve. It happens even to senior people because they have not planned enough. Sometimes in your earlier times, you lack all the necessary access instruments or working instruments. Sometimes pathology confuses us. I will tell you one patient who I started just looking simple L4-5, a little high grade canal compromised disc. I did not understand it. I went inside, I tried, I struggled. I could remove something, but it was not complete. Finally, then I understood that it was attached end plate piece. I didn't have bigger instruments to pull it out. I couldn't cut it. So it was an incomplete surgery which I had to convert it to interlaminar later. Anybody who sees this X-ray, a transforaminal surgeon will say a laddu case for us. Go under local, pull it out, you will find a big piece. We can show the patient, we can take good photographs with it sticking out of our this thing. I also had the same idea. I went in, God had different ideas. It was in multiple pieces and I could just take only half of them. The remaining half in the inferior area was left behind. I couldn't reach, and if I couldn't reach, then I couldn't remove it. So again I had to convert it from transforaminal to the next method. This was another patient. Again, I thought, large single big piece, acute history, yes, you can easily fish it out. No, what happened is, this disc, half of it had migrated through the axilla dorsally. Oh my God. Whenever I tried pulling it, patient had severe pain. I was not sure of it. So again, I went through it. What are the reasons for all these three cases? My overconfidence first, my mistake. And there were judgmental errors on approach, again, my mistake. We should be planning for each and every case as it is our first patient. Intra-op complications, what can they happen? They happen because of anesthesia. Well, let us not go into that. To save all our skins, local is the best bet. Patient is the best neuromonitor. Dr. Christian Morgenstern again emphasized it today morning. GRSA needs intraoperative neuromonitoring, maybe plus minus as per law. Intraoperative pressure, what happens in transforaminal awake surgery, increased cranial pressure can cause central retinal artery thrombosis and blindness. Fortunately, I don't think any of us have had it, but I have had quite a few patients who had pain in the nape of the neck and a mild headache, which they say probably about 45-50 minutes after surgery, and maybe if the pressure is a bit high. What do you do in then? Leave the circuit always open, reduce the pressure, quickly finish your surgeries, remove the cap. I initially started off with the pressure pump, and after that I have always been doing with the gravity assisted fluid movement only. So these are all ways to prevent the pressure problems. Neurologic, we are all waiting for that. L5 is the most vulnerable to L5S1 anatomy if you do a supra-iliac approach in transforaminals, because it is the more horizontal exiting route. Also, if you want to attack more central, highly canal compromised discs and you take a far lateral entry, then please be aware of the exiting route, even at L3-4 or L4-5. Aggressive instrument usage. I have seen some people in their post-op MRI show removing nearly 25% of the annular width and this thing. That is also a little risky thing. Root injuries are bound to happen. Also, dural injuries can happen. This is a patient who I was doing a L5S1 transforaminal. There was a osteophyte, osteocartilaginous area from the pars area pressing on the root. I had osteotomized it. I was trying to pull it out. It was not coming, so I used a bigger 3.5 instrument to pull it out. If you see, I'm sorry, this is just, if you see towards the end of this thing, you will find a small noodle-like thing, which I pulled out along with the bone piece. Patient did not have pain. See that. Patient did not have pain. Patient did not shout with pain. I didn't know what to do. So I pulled it out. This is what I got, noodles from the exiting route. Then I went back inside and I saw, I couldn't really see exactly what was happening because there was nothing else which was protruding out. There was no big protrusion and everything. So I don't know. Maybe I think it must have caught a bit of the nerve and pulled out those 2-3 fibers. What happened to me I had done a post-op MRI also. Nothing is shown on the MRI. The patient had a grade 3 weakness of his L5. Lucky sensation was only about 20% gone. But otherwise, I managed to escape on this. So when you are doing the transforaminals, please in very stenotic areas watch for the exiting route. When you are working in the pars area and otherwise, when you have an osteophyte in the axilla also. The anterior IDs, most of us see usually, unless they are associated with a complete prolapse of the disc, prolapse of the rootlet, you generally have to do not worry about it in the transforaminal things. I also have had my share of 2 or 3 like this. We left it alone. Post-operative MRI did not show any collection, everything. Patients all fine without a deficit. This is something we should all see. I went in for a transforaminal. One of my own classmates' mom, she's a dermatologist. No issues. Passed in this thing, L4-5. I passed in the dilator. I found this pulsatile bleeding. What did I do? I got scared. Everybody should be. I stopped the surgery. I waited in same prone position, removed the needle, removed the guide wire, held the thing in place, blocked the entry for 5 minutes, 10 minutes, made sure the anesthetist and everything is okay. Then I turned her supine, waited, because that you still can have retroperitoneal hematomas and otherwise. Sent her for a CT scan within the next 1 hour. We found that somehow I had managed to hit the lumbar segmental artery in that area. Lucky for me, when we did the CT, that has been blocked. There is no flow there. There is no collection there. So next day, I went in, same transforaminal approach, completed the surgery. So if you have this, please remember the lumbar segmental artery. We do not understand its small variations. This can happen. This happened in L4-5 level. Post-op transforaminal endoscopy discitis, it is bound to happen. Every surgeon is bound to happen his own share of infection. If it is your patient, please own up fast. Please don't wait. No MRIs, no IV antibiotic trials, etc. Treat it early with a repeat transforaminal culture, wash, debris, etc. Bed rest. The secret is maintain the annulus integrity. If you maintain the annulus integrity, I can tell you, even at 5 years, 7 years, patients go back to their work. Not much of a disc collapse is there. We don't see all these things, even with an organism like Pseudomonas aeruginosa. By telling again and again, emphasizing that please do not believe that antibiotics are going to go into disc, there are 2 points which we should always consider. The disc is negatively charged. Only your positively charged aminoglycosides have a good penetration into the disc, normal disc. Your negatively charged cephalosporins, what we already use, most of us use, and your penicillins, do not cross into the disc space as you want in an intact disc. But if the disc has been inflamed for quite some time, they may have penetration. So always, if you are having a pre-operative protocol of antibiotics, please mix 1 aminoglycoside. Second, you can use a neutral antibiotic, something like erythromycin, but that is, we don't get it in IV form and other things. The antibiotic alone is not going to do, so you need to debride, wash and things like that. So I have avoided instrumentation in the few of my post-op discitis patients. My worst things and my results, what I would like to consider and what I would like to inform you all is, anything can happen to anybody at any time. At best, we have to be prepared for the worst, every time. Faster recognition and needed treatment has to be done, and finally, it's all God's will. Thank you very much.
Yeah, excellent talk. Any question for Dr. Palani Kumar?